So everyone. Welcome everyone. Today we are going to have our 30th sessions on artificial intelligence by Apollo Mumbai Critical Care Learning Network. And today it will be a very interesting session. And I request everybody to put all the questions in the chat box. So by the end of the talk, Srinivas sir will take up questions one by one, and then we'll have discussion. And by the time I just start the session, I welcome you all and I introduce Srinivas sir. So he actually needs no introduction. Sir is from Hyderabad and he's the senior consultant, head of the department, director of critical care medicine, Birenchi Hospital. And he is one of the forefront, you can say, the pioneer in Indian Society of Critical Care Medicine, Hyderabad branch. And he has a lot of publication, research, and particularly his particular area of interest is artificial intelligence, which is the demands are growing day by day in the current scenario of the ICU. So that is why we have invited him so that we can have some broad outside and knowledge regarding this upcoming topic. So with us, my colleague Dr. Achilles and Dr. Subhadeep, both of them are working as consultant intensivist critical care medicine specialist at Apollo Hospital, Navi Mumbai. And I am Dr. Gunadhar Padi, senior consultant intensive care medicine. So with this, let's start the topic. And I welcome Dr. Srinivas sir to present the topic. Thank you, sir.
Thank you. And it's a pleasure to be here, and I'm privileged to be invited by the Apollo Group for this session. And this is a topic which is, as has already been said, is a very contemporary topic. All of us will have to face this in future and will benefit from it in future, as we will understand as we go through the presentation. When I was training in critical care, when I was a fellow way back in 2000, 2004, when people were talking about ECMO and lung ultrasound, this is what we were feeling, that this is an abstract topic. Will we ever see it happen in ICUs in our country? Is it really going to come to the bedside? And it has come. And artificial intelligence is something which is going to come faster than we think it is. So why is this important? Why do you think we have included this as a topic for such an important session and trying to understand what we are trying to do? Right now, when we talk about a disease, we don't bother about people who are healthy. But in intensive care and in hospitals in general, we tend to get patients, or we tend to look after patients who are in distress, where the current clinical threshold for detection is some manifestation of a distress. Distress need not always be hypotension, hypoxia, acidosis. Distress can be a tachycardia, distress can be a sweating, distress can be a pain, it can be a discomfort. When the disease reaches a point of causing discomfort to a person, that is when we tend to intervene and try to do something. But the threshold for something which prevents some of these derangements from happening is something that happens between the healthy state and the signs of distress. So the advantage of modern day medicine should lie in identifying patients who have crossed this threshold of a healthy state and are bordering on distress, so that we can ameliorate or cut off the condition or the situation which has caused him to manifest the signs of distress. So we are not looking at extremes of illness, which anyway, as intensivists, we look after regularly. We want to preempt patients from becoming sick, and we want to preempt diseases from adding on manifestations. Like a patient with a tachycardia, he becomes hypotensive and hypoxic. We want to stop it. So that is where we want to understand, and that is where analysis of data, raw data, is very important for us. what exactly is this system called artificial intelligence? It is a system that is endowed with the intellectual processes which is characteristic of humans. Humans are supposed to be intellectuals. We are supposed to have intelligence, such as the ability to reason, discover the meaning of something, generalize our understanding and come to a conclusion, and more importantly, learn from past experience. So you can understand that these are intellectual characteristics. So if this intellectual characteristic, apart from the human mind, is invested in a machine, it becomes artificial intelligence system. The artificial intelligence computer systems are able to perform tasks normally requiring human intelligence that are considered smart by humans. Dr. Gunadhar, just give me 2 minutes. I will just interrupt this. If you can pause the recording, I'll get
Sure,
back.
Sure, sir.
Yeah.
Sure,
Sure.
sure.
I'm sorry, I had to attend to an emergency call, so I'm very
No
sorry.
problem. No problem. You can go ahead.
So now these AI systems are able to perform the tasks which normally require human intelligence, and we consider it as a very smart way of doing it. Like putting, suppose, a ventilator graphic, the ventilator parameters, the compliance of the lung, and the clinical context with the radiological pictures. If you can integrate it and make a decision, that is what we do daily at the bedside, and we think we are doing very smart work. If you can integrate this into an artificial system and make this decision process very standardized and unbiased, then it becomes a smart artificial intelligence system. These applications are also capable of discerning patterns of disease and by looking at scrutinizing and analyzing massive amounts of digital information that is stored in electronic medical records. Now, when you look at this, this looks very similar to evidence-based medicine. But in evidence-based medicine, we are looking at data which is probably 18,000 patients, 20,000 patients, which is again a selection bias. So you don't know which patients you are looking at, you don't know what data you are reading. So it is always going to be somebody who picks up patients with ARDS. So you know that you will look at PaO2, FiO2, you will look at the chest X-ray, you will look at interleukins, you will look at driving pressure and PEEP, and then make a different decision. But there may be other parameters which we don't know can impact the outcome of patients with ARDS, as we will realize as we go through this presentation. So this kind of raw data analysis, collecting all the data, identifying those data which occur more commonly with certain outcomes is what makes artificial intelligence different from evidence-based medicine. So artificial intelligence actually has two types. It is machine learning is a form of artificial intelligence. I will describe that in the due course. Machine learning, that means using machines to learn from data, can be supervised learning or unsupervised learning. Supervised learning is you know the outcome and you know what parameters you are going to understand. So you can classify them. You don't need to remember all this, but these are all methods. It's a regression. You can have a linear regression. That means one parameter versus one outcome, or multiple parameters versus single outcome, or multiple parameters, multiple outcome. For example, if you are looking at septic shock, you can look at multiple variables like vasopressor requirement, white cell count, neutrophil lymphocyte ratio, LDH, procalcitonin, CRP, IL-6. There are so many things, as I will show you, some of which we know, some of which we didn't know till now could influence the outcome of patients with sepsis. So that is supervised learning, but that's always biased because you are already assuming that because this is sepsis, the acidosis should be there, the leukocyte count should be high, the procalcitonin should be high, the CRP should be high. But you don't expect a unknown entity like an HbA1c, for example, to be deranged. But if you put the raw data of all the patients into a machine learning system, you might come up with something that is totally new, and that is unsupervised machine learning, which can pick up anomalies and will reduce the dimensions which you are trying to understand. What is machine learning? So let us look at what the algorithm which I showed you. I will explain each one of those things in a little bit of detail. Machine learning is a subset of artificial intelligence in which the machines learn or extract knowledge from the available data, but they do not act on the information. They will only tell you, if this is the set of things that are happening, these are the possible likelihood. For example, if you look at the IntelliVent system or the IntelliVent mode of ventilating a patient, the Intelli mode on the Hamilton ventilator will look at the compliance, will look at so many other things, and will suggest the best mode and the best method of ventilating a patient. But it does not change anything on its own until you intervene and accept that recommendation. So the machine learning combines the statistical analysis techniques like regression analysis and correlation coefficients with the computer science to produce algorithms capable of statistical learning. So we all have learned about statistics. So putting that statistical knowledge into a clinical algorithm and giving us an actionable plan is what a machine would do, and that is what machine learning will tell. As I mentioned in the previous slide, there are two types of machine learning structures: supervised learning and unsupervised learning. The object of supervised learning or supervised machine learning is to develop an algorithm capable of predicting a unique output when provided with a specific input. So if I say that there is some X activity happening and I want to predict what this activity will ultimately lead to. So if this particular method tells me the function of X, which is the input, will result in an output Y with a constant factor F. This is linear correlation. Somebody is saying they can't see any slides. My slides, are they visible or not?
They are very much visible. Please go ahead.
Dr. Jesse Venel says, I can't see any slides.
Yeah,
we are able to see, sir.
go through
I think-
settings.
Okay.
Yeah, she will have to go through her settings.
Okay. So this is supervised learning. So if I say that I have a patient with chest pain and troponin positive, and patient has a STT elevation on the ECG, it is MI. This is supervised learning. But I have not told that machine to understand that even if these things are normal, if other things which we don't know, if they are also abnormal, it could be chest pain even with a normal troponin, it could be MI with a normal troponin and ECG, that is unsupervised learning. The expectations from supervised learning are that the resulting algorithm will deliver accurate predictions when exposed to new and never before seen data. But these data are presumed to be related to the disease which or the condition which we are going to understand. So when you look at regression and classification analysis, which are part of supervised learning, in regression analysis, the output is a continuous function of the input. In other words, the predictable variable will change. So if some of the input variables change. For example, if somebody has a headache, blurring of vision, and an altered sensorium, then ischemic stroke or subarachnoid hemorrhage or a retinal artery occlusion, whatever you want to understand, this is what regression analysis will do. So it will always tell you that is the output likely or less likely. It will not tell you if all these constellations are same, what is the output? It will say that given the inputs you have given me, this outcome is likely or not. That is regression analysis. Whereas classification learning is a form of pattern recognition, and that is what is important for us. So for example, I will show you when we talk about sepsis, there are several patterns of sepsis. So if there is renal involvement, it's a type of sepsis. If there is coagulation involvement, there is a subtype of sepsis. So this is all identifying pattern recognition. So for example, if I have somebody who has fever, cough, leukocytosis, ground glass opacities, and a normal procalcitonin and hypoxemic on ABG, it should tell me that I am dealing with viral pneumonia. So this is pattern recognition. I'm putting it very simply, but it's not as simple as that because it takes in multiple parameters, as I will describe when I show you about ARDS. So a very commonly used in terms of machine learning platforms is called as a neural network. This neural network will link multiple inputs, whether related or unrelated, and then put them into a network working towards a common diagnosis. So this is called as a neural network. So this is what I meant when I said, if I put data into the network and say something that lives on land and has legs and is a mammal and barks, this is the system, the network should tell me you are probably thinking of a dog. Similarly, if I say that something that lives in the ocean but has flippers is also a mammal but sinks, the machine will tell me you are talking to me about a whale. So this is called as some kind of neural network, basic neural network, which will tell me where all my data is leading to a common endpoint. Similarly, what is a cat does? It's a lives on land, has legs, is a mammal but purrs. So that means the data should tell me you are thinking about a cat. I have not told the system a cat has all these characteristics. So it gathers data and knows that a cat purrs. So it knows that a cat is a mammal, has legs and it lives on land. So it will take different aspects, put them into a network and tell me, look, all these things are happening. So probably you're thinking of a cat. So this is how neural networks would help you. But what is more important for advancement of medicine is unsupervised learning. In unsupervised learning, no instructions are given to the algorithm on how to process the data. So the computer or the system will just take all the data that is put into it, and we look at all the outcomes that have been put into it and correlate which of these data which are in the input are correlating most number of times with the different outputs which have been put into the data set. So the computer in unsupervised learning is asked to extract knowledge from a large set of unclassified data with no known output or a set of rules. So that is where most of the learning, where most of the outcomes seem to be coming in. So it eliminates a lot of bias. So if I suppose, for example, I want to do some study on nutrition in shock. So what I'm going to do is I'm going to see patients with shock. And how do I define shock? I look at lactate, I look at base excess, I look at mean arterial pressure and so many other things and say this is a patient in shock and I will study his nutrition status. But I don't want to do that if I want to look at what are the other manifestations of shock. So I will put all the data of patients in my ICU whom we have labeled as shock by various parameters, what we have thought as the determinants of shock, in addition to those which are unrelated, which we think are unrelated, and then correlate, and then we will identify there are some surprisingly unknown or unthought of parameters which actually will predict shock. So unsupervised algorithms can be very useful in exploratory attempts to understand large collections of data. So over the last 30 years, we have not been able to improve the outcome of patients in sepsis. Why? Because our understanding probably is biased. We are assuming that several important input characteristics are needed for you to get an output characteristic. So supervised learning will create function based on training data. These are all the models. Whereas unsupervised learning does not have a definite output. It extracts knowledge from a large data set and will help you in clustering these patients into a kind of a pattern. So this is what is the difference between supervised learning and unsupervised learning. So let us look at the difference between machine learning versus artificial intelligence. A lot of people, when you talk about artificial intelligence, they will equate it with machine learning. Machine learning is a part of artificial intelligence. Machine learning allows the machines to learn from the data to provide an accurate output. So the output is already fixed. So if X is happening, Y is the output. So what are the determinants? That is machine learning. Whereas artificial intelligence makes the intelligent computer systems work like humans and solve complex problems. So why is this patient looking like sepsis? Is there anything other than the normal characteristics? Is what the artificial intelligence will try to tell you. Machine learning focuses on accuracy and correctly predicting the patterns, whereas artificial intelligence is more focused on whether your decision is correct and your decision is going to be effective for the problems which the machine has detected. Machine learning is a subset of artificial intelligence, and in artificial intelligence, the machine tries to simulate or emulate human behavior. It's like a doctor at the bedside. Whereas machine learning will deals with semi-structured and structured data, whereas artificial intelligence deals only with unstructured data. So what is the general applicability of having understood this concept of machine learning and artificial intelligence? What is the general applicability in intensive care unit? Why are we getting so excited about this? It helps in disease identification. And as I said, it will help you in identifying a disease before the distress has started. And that is where we can do a lot of good for the community. It will also tell you the evolution of the disease. It predicts that if these are the set of data that are happening to the patient, if this is the type of changes which are happening in the patient's system, this is how the disease is going to evolve. So if you put in a first day leukocyte count, a chest X-ray, and the blood test for a patient, it can tell you that this patient will develop mild ARDS in 48 hours and it will progress to moderate ARDS in 72 hours. One of what we already know from machine learning and artificial intelligence is the CORAD score. Now, the CORAD score is something that has come from multiple millions of X-rays of COVID patients in the first wave, and then put together to give us a scoring system and say if this is most likely. So this is the crude and basic example of machine learning as far as critical care is concerned. An interesting aspect of machine learning and artificial intelligence is disease phenotyping. Several diseases now have got different phenotypes. For example, we understood during the COVID pandemic that there is an L phenotype and an H phenotype of ARDS or COVID ARDS. Similarly, as I will show you, there are 4 different phenotypes of sepsis. So each phenotype will have a separate dysfunction, will have a separate outcome. So we need to be able to predict where this patient is fitting into the phenotypic classification, which will help you, therefore, in the last part of the applicability, that is guiding clinical decision. So when you know that a particular pattern is emerging, you will preempt, you will do certain things which will prevent this pattern from evolving into an advanced derangement. So what are the conditions in which artificial intelligence is already evaluated? One of the first areas and one of the most important areas which receives a lot of attention is infection. So it should forecast it should forecast the event. So suppose somebody has some prodromal symptom, your artificial intelligence system can forecast an event. It can forecast a sepsis, it can forecast a septic shock. Such models have been developed for VAP, CLABSI, and multi-drug resistant infections. Yes, we know that there are infection scores and there are predictive scores. There are, you can have models for predicting VAP, but before the patient develops leukocytosis, before the patient develops hypoxemia, before the patient develops infiltrates on the chest X-ray, there will be certain characteristics which you don't pick up in your clinical assessment, but the machine picks up and alerts you that this is a patient who is more likely to develop VAP. So you go on the defensive, you take precautions much earlier before that infiltrate appears on the chest X-ray. That is therefore called nowcasting. That means forecasting is something that happens, but nowcasting, that means what is happening now, what is going to happen now, what is going to happen in the next couple of hours is the future of infection prediction, resulting in increased diagnostic accuracy and higher patient surveillance. And quite often in intensive care units, we err on the side of overaggression and try to treat everything as a bacterial infection when there is an abacterial or a non-infective inflammation. So using unsupervised data, the machines can tell you whether you are dealing with a non-infective inflammation, which will help us in a proper or a more robust antimicrobial stewardship program. So this is what I meant by saying nowcasting. So your diagnostic window, the clinical diagnostic certainty when there is an infection is somewhere here. And here, the last phase, at the end of the thing, you have the clinical discussion and you get the clinical parameters. But before the clinical parameters, there is a phase of forecasting and there is a phase of nowcasting. So this rapidly evolving surveillance systems will help you to prevent the patient from developing the florid clinical features or clinical presentations of an infective process. So the gray zone is where the artificial intelligence systems can tell you, am I dealing with an infection or am I not dealing with an infection? So where does it work? At the start of therapy. At the start of therapy, your antimicrobial stewardship goals are a correct diagnosis, an early therapy initiation, appropriate choice of antimicrobials with the correct dose and the correct dosing interval. So here, artificial intelligence and machine learning support comes in the form of predicting the infection, giving you a better diagnostic accuracy of what the organism is likely to be, helping you in patient surveillance, and differentiating inflammation versus infection. So once you start the therapy, during the therapy, it will guide you in pathogen identification and de-escalation by enhancement of the microbiology techniques and helping you with the AMS programs and help you for a timely cessation of antimicrobials earlier than what your conventional clinical wisdom would tell you. This is not something which is a figment of imagination, and this has been predicted as way back as 2008 by Salisbury et al. From a pre-symptomatic prediction of sepsis in the intensive care unit. This was a very rudimentary computer-based system which looked at just the clinical parameters of sepsis as was known in those days versus the cytokines alone, and combined them to find out that a combined machine-based combination of cytokines and clinical assessment can give you a better positive predictive value and a better negative predictive value for sepsis among intensive care patients. And when we look at the data from clinical phenotypes of sepsis, you can't look beyond this excellent article published in the JAMA last year, which tells you that there are 4 different phenotypes of sepsis: the alpha phenotype, the beta phenotype, the gamma phenotype, and the delta phenotype. They looked at close to 20,000 patients with almost the same age group and gender, with a good racial distribution, and they found that certain parameters which we routinely presume to be happening in all patients of sepsis happen only in certain phenotypes of sepsis. For example, your CRP elevation happens very high in gamma and the delta phenotypes of sepsis, and it doesn't show up in your alpha phenotype of sepsis. Your white blood cell count elevation is not consistently seen across all the phenotypes of sepsis. But what is more surprising for us is certain parameters which we don't give much importance when we talk about a septic patient, like a bicarbonate, for example, a AST, for example, a bilirubin, for example, can help you to differentiate and discriminate between the different phenotypes of sepsis. If you look at the different phenotypes of sepsis in this cohort, you would realize that the blood urea nitrogen seems to be a good predictor of the beta and the delta variants of phenotypes of sepsis than the alpha and the gamma delta types of sepsis. Similarly, bilirubin seems to be a discriminator between the different phenotypes of sepsis. So this we would not have understood, or we would not have realized, had we not put all the raw data into a computer system and tried to see the pattern. So with the help of this, we have got this excellent color diagrams which can tell you that if your pulmonary, if your neurological, hematological and pulmonary systems are the predominant aspect, you are looking at an alpha phenotype of sepsis. Whereas if you look at the renal and your hematological manifestations as your predominant manifestations of sepsis, you are looking at the beta phenotype of sepsis. And if you are looking at cardiovascular, inflammatory and pulmonary manifestations, you are looking at the gamma phenotype of sepsis. Why is this important? Now, when you look at sepsis studies, we know that there are the ACCESS, the ACCESS, the PROVESS, and the PROCESS studies. These are landmark studies in sepsis, and we tend to club all these studies as the same, and we try to interpret the results for all patients with sepsis. But if you look at the distribution of the phenotypes of sepsis among these good landmark papers, you see that there is such a heterogeneity in the phenotypes included in these studies. The authors of these studies did not know this. Only when the raw data from these studies was requested and put into a computerized algorithm, we came up for this. For example, the PROVESS study had a higher percentage of the delta phenotype. And when you look at the other studies, there is such a variation in the different phenotypes. So you can't look at one particular study on sepsis and say that the results are extrapolatable to all aspects of sepsis. All aspects of sepsis, because each one is dealing with a very mixed bag of phenotypes of sepsis. So that is the reason why the results of some studies are not being, we are not able to replicate it into clinical practice. So what can AI do in sepsis? So what can artificial intelligence do in sepsis? The artificial neural networks can predict sepsis with high sensitivity and selectivity. And these algorithms, the artificial intelligence sepsis evaluation algorithms can precisely predict sepsis 4 to 12 hours prior to clinical recognition. Even if you use the QSOFA score, the artificial intelligence algorithms will predict sepsis 4 to 12 hours, which is, like gold mine for the management of sepsis. And we now have seen how the 4 clinical phenotypes were detected relating to clinical outcomes. The other area where intensivists still are struggling to find the magic bullet and the best way of managing patients is ARDS. And Pritankar Das and his colleagues, Pellegrini and others, have come to the understanding that supervised machine learning is quite good for the early prediction of acute ARDS, acute respiratory distress syndrome. And surprisingly, the features, the parameters which help them to predict ARDS very early are not a chest X-ray, are not just a chest X-ray, blood gas and other aspects, but unexpected entities like a lactate, like platelet count, like creatinine. All these aspects have a bearing on predicting a respiratory distress syndrome. So this combination of multiple parameters, which are not essentially related to the respiratory system, can predict the development of ARDS 4 hours prior to the conventional PF ratio with a good area under the receiver operating curve. You can see with a high specificity and sensitivity, but it fades off at 48 hours. But if you can do it earlier, probably we can save a lot more patients. Similarly, similar to what we found in the sepsis, machine learning classifier models have been developed which can identify acute respiratory distress syndromes, phenotypes using readily available clinical data. You don't need to buy expensive equipment and monitoring tools to get these phenotypes. So again, Pratik Sinha et al. Looked at a lot of parameters like demographic characteristics, respiratory characteristics, the vital signs, and the lab tests. And they looked at several innocuous looking entities like the respiratory rate, breaths per minute, systolic blood pressure, platelet count, hematocrit, and sodium, and were able to come up with a very good discriminatory parameter scores, including interleukin 6, protein C, the TNF alpha, and they were able to come up with a very good scoring system, which classifies ARDS into two phenotypes, the hypo-inflammatory ARDS and the hyperinflammatory ARDS. And they found subsequently that the driving pressures, the need for ECMO, the need for prone ventilation were quite different from the between the hypo-inflammatory phenotype of ARDS and the hyperinflammatory phenotype of ARDS. So quite different from the L and H phenotypes which we were looking at during the COVID pandemic. This seems to be the game changer as far as scientific management of patients with ARDS is concerned. And it looked at the gain or the contribution. You find that it is not just the respiratory variables which make a contribution and give you a good predictive value, but simple things like bicarbonate, vasopressors, creatinine, heart rate, right, bilirubin, albumin. These are all players which will give you a prediction of what type of ARDS you are doing. So if you are looking at ARDS, it's not just your ventilator, your lung ultrasound, your compliance, your graphics, and your blood gas, but the whole armamentarium of tests which we do on patients which can be utilized. And this we realized only because the raw data, which was not biased, has been put into a machine, and the computer then put a pattern to it, and we have come up with this kind of recommendation. And this scoring system has got a very good ROC. You can see it's close to 90% of sensitivity of predicting these patients with ARDS. So if you look at the mortality, the patients with the hypo-inflammatory phenotype required lesser PEEP and tend to survive more compared to those who had a hyperinflammatory ARDS. So this, if you can predict when the patient gets admitted to the ICU, you can predict who is going to develop a hyperinflammatory ARDS or a hypo-inflammatory ARDS. You can tailor your ventilator settings subsequently also. So once you know that your patient is going to, you can predict it. You can also stratify the risk for these patients with acute respiratory distress syndrome. So Zyberg and Prahlad tried this and they looked at different time periods. Like you make a diagnosis of ARDS somewhere here, but if you collect data 6 hours prior to the point where the diagnosis of ARDS could have been made, and looked at certain important characteristics like heart rate, hemoglobin, albumin, and then platelet count, you are able to identify those patients who are at a high risk of deterioration with ARDS. And this can pick up ARDS earlier than your conventional chest X-ray Berlin definition with a good ROC for positive predictive value. So in ARDS, AI can identify more cases of ARDS as compared to conventional teaching and chest X-rays. It can predict ARDS up to 48 hours before its actual onset, and it can actually identify the phenotypes of ARDS and will help you stratify the patients for ARDS based on the electronic records. Cardiovascular diseases, right? Cardiovascular diseases like MI, you tend to look at imaging, right? You tend to look at echocardiography for disease classification and diagnosis, risk prediction and patient management. Several of the raw data which are recorded from echo machines can actually be fed into learning algorithms, and you can get disease classification much better than the existing algorithms. So some of these companies which are now manufacturing echo machines have actually integrated some of this data to tell you what to do next for the patient on whom you are performing an echocardiogram. Similarly, ECG, what we normally know as ST elevation, T wave inversion, QT prolongation, there is much beyond that when you put this raw data into electronic analysis systems. Similarly, circulatory failure in the intensive care unit is something we all see, whether it is cardiogenic shock, septic shock, hypovolemic shock. Early prediction of circulatory failure can help you to identify those patients who need more aggressive monitoring. If you look at again parameters, you can see that parameters like peak inspiratory pressure on the ventilator, we don't think about it. C-reactive protein, we don't think about it. Blood glucose, we don't think about it. The sedation score, we don't think about it. But these are all predictors of early onset of circulatory failure with a good contribution percentage among these patients. So you can see that the early warning signs based on these parameters can help you to identify circulatory failure much earlier with a good AUROC and can predict those patients 8 hours before the deterioration happens. So that is a good window for us to intervene and try to put in the therapeutic processes for these patients before refractory shock comes in. So as far as machine learning and supervised learning is concerned, where do we stand now? So we at supervised learning, we know what we are using. We use several techniques. So if you look at the target levels for sepsis and ARDS, we are at a very high level. The target realization level, we are nearly between 4 to 7. Whereas for sepsis resuscitation and glycemic control, there is still some way to go because the target reached level is still 3 to 4. So we don't know where we are doing, but this is a definite positive sign for more scientific management of patients with sepsis, ARDS, circulatory failure, and needing intensive care. Other emerging areas where artificial intelligence is going to come in a big way is weaning from mechanical ventilation, as I said before, predicting AKI, not diagnosing, but predicting AKI, telling you which patients will need RRT, which is a big debate in intensive care circles. Stroke identification before you get the hypertense MCA or the insular ribbon sign on MRI, and stratify the risk. Antimicrobial stewardship program, as I said before, and post-cardiac arrest neuroprognostication. So these are some areas where a lot of work is going on in the field of artificial intelligence. What are the limitations? Is it all so good and so exciting? No, you need to explain, because suppose LDH is high and you're talking about circulatory shock, you need to explain why the LDH rises in septic shock. And that is where basic research has to come in to help you to interpret this data. And if I develop a machine learning platform and algorithm in my unit or in my city, it should be reproducible in another environment, like a Mumbai, like a Chennai, like a Bangalore, whatever. And ethical concerns. Are we going to act upon information thrown up by a machine learning platform? Does it stand a legal scrutiny? This is something we don't know yet. So in summary, innate intelligence is focused on stereotypes. So sepsis means X phenotype. That is broken by artificial intelligence, which circumvents the routine. The turnaround time is shorter for a machine learning platform to give you a decision. And evidence is building, but the future path is very clear that AI is going to be the way to go in healthcare. Therefore, I personally feel that critical care curriculum, internal medicine curriculum, or postgraduate curriculum should include artificial intelligence and machine learning. As Amit Ray, one of the pioneers in AI, said, as more and more artificial intelligence is entering into the world, more and more emotional intelligence must enter into leadership, which accepts that this is going to be the way of life, and we should not see it as a threat to our professions or careers. Thank you very much for your attention and for giving me this opportunity.
Thank you, sir.
Thank you very much, sir. It was really nice. I mean, eye-opener. So artificial intelligence can bring such a big revolution, and we will be able to predict the outcome and mortality. I think we are just waiting for the day that the artificial intelligence and machine learning becomes so much empowered that we all be benefited. It will be a great benefit to the humankind, and I think more and more work should be done. But at the end, what I feel, so I mean, as you said, like supervised machine learning has its disadvantages in terms of the factor called as bias and all that, and with unsupervised, the bias factor probably may be removed. So how can the unsupervised machine learning will be able to be more superior? Like the bias is the only factor, but apart from that, because we need to guide the machine as well, pertaining to what they should do and what are our aims and objectives.
So
Yeah.
the reason why, Akhilesh, we need unsupervised learning is to take out the stereotype of a disease. For example, if I want to say if my patient has heart failure,
Yeah.
I want his JVP to be elevated, I want to be BNP to be higher, his heart rate to be high, his ejection fraction to be abnormal, his IVC to be dilated, right? Now that is extreme. Now, even if I institute the best of treatment for such patients, there are a percentage of patients who will end up with refractory heart failure. That is because I am entering into this diagnostic algorithm with the understanding that unless these 6 or 7 manifestations are there, it is not heart failure. Whereas if you put the raw data, when the patient did not have all this, but came to the hospital for something else, if you put all the data, 1 million data sets into an algorithm, it will tell you, look, apart from the 6 parameters which you are focusing on, there were 10 other parameters which could have told you that there was heart failure in this patient before the veins started engorging. Then you can intervene. That is where unsupervised learning is very important. And that is what the JAMA article on sepsis has shown us, right? We have got stereotype.
Right.
We all believe that all sepsis is the same. It's not
Yes.
so. So why the results of reverse study done 20 years ago were not validated by the subsequent troika of resuscitation studies? Why the original address study, which was looking at activated protein C, looked very promising, subsequent trials did not show, is because probably now in retrospect, they were looking at different phenotypes of sepsis.
Yes.
You understand? I mean, see, if I'm looking at, why does, some studies on acute kidney injury in sepsis, some of them show good results with early initiation of RRT. Some of them don't show the same results in, why does that happen? In the same year, you had 4 publications coming out in the JAMA, 2 arguing in favor of early RRT and 2 arguing against early RRT. Why did this happen? You look at the Apache scores, you look at the SOPA scores, you look at the age of the patient, and then say at baseline, both the groups were equally matched, right? Now, end of the day, they are not actually matched because the 4 studies were probably looking at 4 different phenotypes of sepsis.
Yes, yes.
So when I want to extrapolate this kind of data into my clinical practice, it helps me if I can identify which phenotype of sepsis I am dealing with and which study among the thousands I have studied has actually included this phenotype of sepsis. That is when my decision making becomes actually scientific. Till then, I'm shooting in the dark.
But do you think, you don't think like if you're given so many parameters to the machine may not come up with final conclusion. It may give you some possibility, like this may be possible, that may be possible. So it
No,
may give you multiple possibilities
it may be,
as an
but
outcome.
it
As an
may
outcome.
be. That's
Then
why
it
I
will be
said
very difficult for us to comprehend and come up to a final conclusion. We may
true.
also get confused at times. Do you
True.
think
That is
so?
what
Yeah.
I said as a limitation, right? Limitation of AI is explainability, right? Now, keeping medicine aside, the FIFA World Cup is going on, right? There are at least 20 different machine learning, artificial intelligence predictions, right? Which have said which group teams will go into group of 16, which teams will qualify for the final, which will quarterfinal, semi-final, and final. If you look at all the 20 algorithms, they're all telling you different people will qualify for the round of 16, but ultimate winner is the same. They're all predicting only one team will win this World Cup. We don't know who will win, but the prediction is only one team will win the World Cup.
So
Right?
to just extend your talk, if I can say, there are other very good areas where actually this is going to be one of the dominant player, like gene editing, like clinical drug development, clinical research trials. And I think those are the game changers where we'll get newer antibiotics and we can have combat the antibiotic resistance.
I mean, I am an intensivist and I want to focus on critical care. So I didn't talk about oncology, right? Now, oncology is an area where machine learning is be a big game changer, right? It's not just the immunohistochemistry and flow cytochemistry and cytogenetics which determines the chemotherapy. There is much more to it. If you put the entire histopathology, cytogenetics data into an AI platform, your chemotherapy will be absolutely divergent for the same cancer for two different individuals. That's where it's going to come very soon.
So there is one question, sir. So the question is, will it going to take a job from the intensivist, or if somebody wants to practice or develop his career in artificial intelligence, what are the options available for him?
Guru Prasad, I don't think you should be worried about your job. Because if the algorithm tells you that you need to write meropenem in this particular dose, without your signature, no pharmacy will give the meropenem. No computer signature will give the antibiotic to the patient. We don't need to worry about it. At the same time, we should learn how to use this. We should not, when we were training, some people said, when we were focusing on learning lung ultrasound, they said, you're wasting your time. Okay. They have been left behind now. Right. It takes a hell of a lot of catching up. Right. 2002, 2009, when H1N1 came into the country, when we started doing ECMOs, people said you're wasting your money, time and money in learning ECMO because it is never going to be widespread in this country. What is today? Hospitals have 15, 20 machines, right? This is going to be that. We should not be afraid, right? T20 came, right? Even Rahul Dravid tried to play T20 because you have to learn. I mean, you have to keep yourself abreast.
So what are the career paths, sir? What are the
career path? Career path, I can see that first thing, an AI capable intensivist will be an asset to an organization, because he can develop algorithms for so many things in the ICU, which you haven't thought of, right? Antimicrobial prescription, vasopressor weaning, AKI, RRT initiation, antimicrobial dosing. There's so many areas. So as a career path, you can actually become somebody who will guide people by having your own platform and telling them that your patient fits into this treatment category. You will become the chief advisor for all critical care decisions. So there is definitely a path, career path with artificial intelligence.
So any such institutes who are offering courses?
Yeah. There are multiple institutes across the world, in the United States, Australia, New Zealand, Europe, South Africa, which are offering 2 years, 1 year training programs. But I must tell you, you need a little bit of mathematics. You need to understand a little bit of mathematics for this. You need to understand probability. You need to understand a few things. So, but otherwise, it's a fun thing to learn.
So I have a question in my mind, like, we have response variations, like, if the patient is suffering from sepsis, we know that the response to the treatment or the patient's symptomatology may differ from patient to patient and all that. Okay, so if there is such a hell and heaven of a difference between the response of a patient from the other individual, how would these machines be able to predict whether this patient will be able to respond or not? I know there are a lot of algorithms, there are a lot of trackers that the machines will follow, but it's still, I still have a, querying.
So I give you an example. I give you an example. You have 2 patients with multi-drug resistant E. coli in your ICU. Both have grown the same multi-drug resistant E. coli in the urine, right?
Yes.
One is responding to meropenem and one is not responding to meropenem. Your molecular diagnostics is telling you both are same, right?
Yes, absolutely.
So your AI will tell you why that second E. coli is not responding to meropenem and what will work for that bug. It looks beyond molecular diagnostics.
Okay. So will they be able to evaluate the genetic makeup of the individual?
In fact, the antimicrobial stewardship algorithms of AI will tell you without a blood culture what is the patient's organism, what is genetics, what antibiotic you should use within 4 hours.
Okay. It's amazing.
This is good. I mean, I'm really looking forward to the day that enters our ICUs and we'll be able to use it.
But will it be same for patient population also, because there is a lot of variation amongst the population?
That's why this is very important, because you do a randomized control trial, right? You do randomized control trial. You do a multi-center randomized control trial. Probably you will get data from 100 centers. You may get a 30,000 data. But if you take a machine learning, if you suppose, for example, I want to do a machine learning platform for malaria or dengue in India, right? I will get 10 million samples. I will get data from 10 million patients. How long do you need to do a randomized control trial to get 10 million patients?
Yes.
Right. So if I get raw data from laboratory information, radiology informatics, lab informatics, electronic medical records, and dump them into an algorithm or a machine learning platform, within a span of 2 weeks, you will get a definite pattern recognition and unsupervised learning recommendation for this 1 million patient. That data will be the most robust data.
Right. Sir, what is the implication of legality?
I don't know, because since it is not validated and since the explainability is not very good, we don't know. But still, I think it's just a matter of time before it becomes standard practice.
And in fact, now this artificial intelligence is doing a lot of things outside ICU, in the home care, in the step-down care.
So see, we all learned, we all did it, during COVID time. We sent patients home with BP monitors, pulse oximeters, and monitoring them from home. So that is a very rudimentary early form of artificial intelligence, right? Now, when you outsource radiology, right, there are lots of people who do teleradiology, right? 50% of these people who do teleradiology don't have a physical radiologist sitting at the other end of the screen. They only have an AI software. So it will just look at your CT, MRI, and then look at some 160 parameters and give you a report. There is no radiologist reporting it.
Right.
So we have Dr. Subhadeep, he wanted to speak about.
Yeah. Please.
Hi.
Subhadeep?
I'm unable to hear you, Subhadeep.
Voice is breaking. Your voice is breaking.
Interesting talk. Probably. Oh, you're not able to hear me? Can you hear me?
Yes, right
No.
now.
No.
Yeah. Can you hear me? I have turned my video off.
Yes,
so that
yes.
Yeah.
signal becomes a little better. So now it's very interesting thought, interesting thing. And the most interesting part of the whole session is that the thing is artificial intelligence takes into account of a host factor into the treatment. So that is the most important aspect probably we can take from the whole talk. The host factor in the human being, the treatment of the human being is extremely diverse. So we do not know. That is why probably to one patient the meropenem works, and to one patient the meropenem doesn't work. So if you can classify into those host characteristics by any kind of pattern recognition system, that will be obviously great thing. My only question is that to you, probably, sir, is that so do you really practice this artificial intelligence in your ICU, and how do you do it? So, and do you have a kind of machine where you feed all the data every day and then you try and find out the recognition, do a pattern recognition, or you have an established system that already tells you regarding this patient-based characteristics?
I wish I was using it on a daily basis, but I am actually in the process of building a database for simple things like a WAP and a UTI to predict people who are likely to have MDR infections, who are likely to have pyelonephritis. So I don't use it regularly right now as a routine, but I'm expecting to do it in as early as the next 2 years.
So how are you planning to do it, sir? What are taking the patient's data on a day-to-day basis and feeding it to the computer?
What we are trying to do is to gather raw data for the last 10 years for specific conditions and develop an algorithm which is an advanced phase of development.
So in that case, probably we can also participate probably if we get more and more patients' data. That
so when I get a decision-making tree and algorithm, it has to be tested in other environments. At that time, it becomes a multi-center participative evaluation.
Right. So in those cases, we can collaborate other hospitals.
Yeah. So Dr. Rahul Agarwal says, can it help in clinical medicine? Yes, that's what I said about MI and heart failure and all that. Yes, it is. Actually, to put it short, artificial intelligence and machine learning are going to be the future of personalized medicine. I want to give personalized nutrition to a patient. It is not Nutri-Score. It is not any other albumin, pre-albumin, ferritin, transferrin. These are not the ones. You need to put raw data and get into AI. There are a lot of people, researchers working on AI platforms for nutrition in the ICU. So personalized medicine will be based on AI in the future.
Correct. So probably in next few years we'll see the ICU, what is called as the next level of ICU.
Definitely, yes.
And those time I think intensivists are the most valuable asset.
So all of you would be most prized assets when it comes.
Yes, sir, absolutely. So okay, so I think we don't have any other.
So AI trained intensivist will be the most valuable asset at that
There
time.
may be an FNB in AI. I don't know. I don't know.
I think we should look at that level of curriculum, sir. Definitely.
Yes.
ISSM should also take some.
Yeah, I will actually put forward this for to the ISCCM. I'm going to talk about it in our next meeting, EC meeting.
Yes, sir. Thank you.
Is there any other hospitals which is working on this artificial intelligence based system?
Yes, across the world, there are multiple people working. United States and Australia, a lot of hospitals are working.
No, in India.
I'm not sure, because in India, we very hesitate to share data. I think somebody has posted that HN has a department of AI, so maybe it's not far off for you guys.
But I think still it yet to develop.
Yeah.
No, but I think there should be more and more work on this artificial intelligence. We are all dependent upon the Western data, Western literature, Western
Yeah.
research, and all that. I think we should have our own data, our own algorithms, and our own applications which will help us, our own intensivists at large. That is what I feel so. And that is the need of the hour, actually. Rather than being dependent on the others, we should be self-sufficient.
Yeah.
Atmanirbhar Bharat is one of the, one of the part of that.
And we are a tech savvy country. The brightest minds in information technology come from India.
Absolutely.
So I think we should be the leaders in this field. We should be.
Yeah, and I would request you, sir. We would request you to take a lead on this, and we would definitely would like to follow your
No,
footprints.
it's a
and probably
passion
we'll
for
be
me. Definitely, I will be trying, but there
Yeah.
will be more people who will be interested. So definitely, yes. Thank you.
Definitely, sir, definitely.
able-
So,
we will be definitely be able to join the hands with you, sir.
so lovely session,
Really.
wonderful presentation, and
No, really,
thanks.
yeah,
We'd like
thank you
to
very
hear
much, sir.
our sessions.
Yes,
If you
thank you very much, sir, for this wonderful session.
Thank you. Have a good day. Bye bye.
Thank you, sir. Thank you.
Thank you very much, sir.
Thank you.
Bye bye.
Thank you, sir. Bye bye. Good night, everyone. Thank you.
Thank you all.
Can we predict what is the next lecture? Hello.